right, last talk of this session is Tom Pottage. Tom is a biosafety and biorecovery team leader in the Biosafety, Air and Water Microbiology Group at the UK Health Security Agency. Now, if that doesn't sound familiar to you, they were recently Health Protection Agency and Public Health England. They try to change their name at least once a year. He's been a group in that group for over 18 years. Wow. And working in areas such as decontamination, remediation, environmental microbiology, aerobiology, and waste management. You may also know him as the lead or one of the leads for the UK Recovery Handbook for Biological Incidents. And Tom is also impressive in that he took his practitioner expertise to the Ebola outbreak in West Africa a few years back in Liberia. So I'll turn it over to Tom.
Thank you. It looks like I've got my poster presentation up rather than the oral presentation. So I can do this instead, but it'll be a bit shorter. Okay. Anyway, yeah, I'm here to speak today about some of our experiences in sampling in hospital, domestic, and office spaces for mpox virus through the year. Well, I say through the years, from about 2019 onwards as well. So that incorporates mpox cases prior to the public health emergency of international concern, sort of started in July 2022. I'll carry on. I can memorize the first few slides, so it should be okay. Mpox virus, and obviously, as Sean mentioned earlier, it used to be called monkeypox. It's recently undergone a name change. So if I do say monkeypox, I just slip back into the old routine. It's a double-stranded DNA virus. First identified, I think, in 1958, but actually the first human cases were seen in 1970 in the Democratic Republic of Congo. And it's primarily a zoonotic infection in small rodents and small mammals. But obviously there is secondary transmission between humans, and that is via aerosol and direct contact between people, and also through fomite transmission as well. Okay. I'll carry on. I'll try and hold these up if anyone can see. I don't know if you want to just crowd around in a circle, it might be a bit better.
Sorry, Tom.
That's okay. So the next slide would be a nice graphical representation of how it spread through the decades since the first human case. So really in the sort of 70 to 79, it was concentrated in West Africa and Central Africa and sort of DRC. And their cases were relatively low, as you might expect due to the reporting mechanisms. Through the 80s, actually, there was quite a significant increase in the DRC and sort of moved a bit away from West Africa. And into the 90s, it was mostly concentrated in DRC in terms of the human cases. It was really from 2000 onwards, 2009, we started generating some headlines where there was 47 human cases in the US, and that was linked to giant Gambian rats, which are imported into pet stores. And actually then there was further contamination to prairie dogs as well. But actually, through that decade, through the 2000, 2009, there was a 15-fold increase in the number of human cases in the DRC, and that wasn't really reported at all. And similarly, in sort of 2010 to 2019, there was 4 imported cases in the UK, 1 in Israel and 1 in Singapore, and these really hit the headlines. But actually, sort of, there was again an increase in the Central and Western African human cases, which didn't really make it. Again, I'll just carry on now. Pass the slides around so people can actually have a look and see what's going on. So basically, this slide was just going to have a little bit about the UK cases, imported cases. So we had 2 unlinked imported cases from Nigeria in 2018, and that actually led to a secondary transmission to a healthcare worker. And that was actually linked to linen bed changes in the hospital where one of the patients actually stayed. 2019, It's actually a bit more of a case study. We had one imported case, 2021. We had one imported case in a large family, and that led to 2 secondary infections as well, which were treated in hospital. And then in 2022, we had another imported case. And so basically within those cases, we've had 8 prior to the PHEIC. So I was going to talk about sampling technologies and how we actually do environmental sampling. Megan covered the surface sampling very well earlier. We use flock swabs, and these are sort of moistened in universal transport media, although we have used viral transport media as well. But we also use what we call blue and virus sticks, which are macrofoam sort of quite big sponges, pre-wetted sponges on the end of a plastic stick. And then we'll actually have a template. So we generally use a 10 centimeter by 10 centimeters template where we can actually go over surfaces, and we can try and quantify that, or at least semi-quantify what we're recovering. But we find the flock swabs are actually really useful for intricate areas as well. So if we have things like TV remote controls or mobile phones or push call buttons in hospitals as well, we can actually get onto those areas with those swabs. We also do some air sampling. And as Sean mentioned earlier, we use gelatin membrane filters as our primary go-to, solely because it's easy to process. And then we can actually either use PCR or we can use viral isolation on those samples going forward. We sample about 50 litres a minute, just because that's sort of a good level that actually our Sartorius airports can actually run those gelatin filters at. If it was a cellulose nitrate, they can run higher, but the pressure differential across those gelatin filters actually means we have to run at slightly lower flow rate. And we can use those air samplers to actually do background samples. So we can do that in a room, so we can see if there's any re-aerosolization of agents as we're moving around doing other surface samples. We can actually then air sample very close to any procedures which might generate some aerosols, so looking at sort of bedding changes or actual aerosol generating procedures in hospitals. But we can also use those as surface sampling for porous surfaces as well. So we can actually move the gelatin filter across the surface of a bed, of a carpet, of a floor, and then we can actually try and capture any particles that way as well. And then we can process those again through PCR or viral isolation. So moving on to 2019, this is an imported case from Nigeria. The patient or the infected individual caught a flight, landed in a UK airport, caught public transport, which was a bus down to his bedsit or their bedsit in the southwest. And now bedsit, if you're not from the UK, is a house of multiple occupancy where you rent a room out and you have some shared facilities, but you have your own bedroom. So we went in, and there's some pictures which aren't very flattering of me there, so it's quite good they're not on the screen. But we went in there and we completed multiple surface samples using swabs, but also we did a lot of air sampling of porous surfaces and also sort of just round and background samples. And then about 4 days later, when we tracked the bus down, we actually went onto the bus and did some sampling there as well, so we could work out if there's any infection risk at all. In terms of the actual results from that, we found it everywhere basically, and actually quite low CT values down to sort of low 20s, right up to sort of 37, 38, which was close to our limit of detection for the CT for the PCR. And actually what we tried to do was then take a selection of those samples, whether they be air samples or swab samples, and a range of CT values. And we wanted to take those forward for viral isolation, so we could try and see if there was a cutoff, a point where if we had over a certain CT value, then we weren't going to get that. But actually what we found was those samples we took forward for viral isolation, we actually found it quite far and wide. And actually over like 66% of those samples we took forward to isolation we got positive from. And I had a nice picture of one of the virions as well, which if you squint you can see it. You close? Yeah, that's cool. I can go back so you can see some samples. That's okay. You can take it out of the registration fee. Free lunch tomorrow. So this is just some of the graphical representation of where all the human cases have been. This is the old presentation as well. Okay, slightly different. Skip forward. I shall come back to these slides because I've changed it slightly. So here we can just see our swabs and sort of the blue sponge swabs there and our sampling pattern. And as Sean showed earlier, just the MD8 airport there. And also we can use smaller button samplers as well. So we can wear those and use those as personal samplers. So we can have those near our breathing zones, and we can work out what, if anything, we would have breathed would actually be captured in that as well. And this is us in our Tyvek suits ready to go in. And this is sampling on the bus because I was taking a photo that time because I managed to delegate the sampling. In terms of as I was mentioning about the CT values, we've got a range of the samples here and they're all positive apart from a few at the bottom. But this is where we took some forward for viral isolation, and we can see that actually we've got even at quite high CT values, we're still isolating there. And this is one of the virions there, but it's all in a paper by Atkinson and Burton, which was published last year, which is quite good, quite extensive. So moving on, and I'll go back just a couple of slides because I changed the order. So what we have here is what we call the high consequence infectious disease. An mpox virus is actually classed as one of these within the UK, and we have a definition down by the UK government. And really what it says is there's a risk to the community and healthcare workers from spread of infectious disease, which is actually sort of got quite a high fatality rate, or postulated to have a quite high fatality rate. So we treat these people who are in specialized treatment facilities, and these are split down to either contact or airborne. So you have a contact HCID viruses here, an airborne HCID agents, because there's one in there which is pneumonic plague, and these are treated slightly differently. So and we have a range of facilities and hospital for treatment centres in the UK that can deal with airborne HCIDs, and slightly different, a smaller number of contact HCIDs as well. So in, okay, sorry, it's all out of order. So moving on to 2021, this is actually the 4th imported case into the UK. And it was, initial case was a family member, an adult family member, who had a large family with them. And they went into an HCID ward, and sampling was undertaken. And we can see that the sampling, again, sorry, excuse the small figures there. But what we can see is the sampling, the positivity of the CT value for PCR was in the 30s, low 30s. And then one of the things to mention in terms of HCID wards, they're cleaned very regularly with sort of sodium hypochlorite wipes. So actually, they're always looking to reduce any contamination on surfaces and reduce the risk to healthcare workers. So actually, it's not really surprising that we're getting sort of a higher CT, and actually whether these are, we took them forward for viral isolation, but at the time we didn't know. So we sort of just wanted to check and see how positive they were for PCR. Then 2 further family members became positive for mpox, and further sampling was undertaken, and we can see lots of positives in sort of case 2's room. In case 3, it was a very young infant, so actually they didn't move. They're quite immobile on the bed or actually in the toilet, so we didn't actually get much spread around that room, and that might also be because of the regular cleaning. Then after case 1 became negative, they were then actually put down into a step-down room, which is still in the HCID area, but it allowed them to help look after the young family members as well for going forward. And what we actually did here in each of these rooms, we took the 2 most positive samples, and actually any samples that were positive post Decon, and we took them through for viral isolation. And what we only found was 2 positive samples for a replication competent mpox virus. Now we move on. So this sort of raised some questions for us. In terms of actually wanted to address the suitability of IPC, so that's infection prevention and control measures. And also the PPE used in the isolation wards. We really wanted to see if that was suitable protection for those healthcare workers through the sort of fomite transmission, but also the aerosol route as well. And we wanted to gain some information on the level of contamination in risk environments. So we wanted to look at patient rooms, but also we moved into workplace environments as well, because we managed to have a case which we'll discuss in a second. And then we also, as Dr. Wong mentioned earlier, there was also a case in Singapore, which is the detection of mpox virus during bed linen changes as well. And we wanted to have a look at that because obviously the case in 2018, which was a healthcare worker, was associated with a bed change as well. So this is actually in the Royal Free Hospital in London. This is an airborne HID room. It's split into 3 areas. So we have the ante room, and we have a clean area and a dirty area. We have you can just about see it there, a bit of tape on the floor to mark out where donning and doffing of PPE happens, and sort of the decon of PPE as well when they come out of the room. We have the patient room here. It's very minimalistic. Patients can be in there for up to 30 days, so it can be quite difficult and hard on them. But actually, they also have the facilities to undertake most of the treatments which are required in those areas as well. And then that leads on to a small shower room with toilet as well. And this is all under a negative pressure cascade as well to sort of try and help restrict any aerosols from actually leaking out. So this is the least negative. The room is more negative than the ante room, and then the bathroom is the most negative area. So air will transport in that direction. And this is some sampling we did under the PHIC incidents in 2022. And this is just a graphical representation of an HID room. And again, we managed to undertake surface sampling and air sampling within different areas of the actual sort of rooms or the suite. And we found extensive surface mpox virus contamination via PCR. And also we found positive air samples whilst we're in there with patients, but also during bed linen changes as well, at quite high levels. And also the swabbing of the PPE for the healthcare workers as well, rather unsurprisingly, was actually positive for DNA as well. And then also we took forward some of those samples again for viral isolation. And mpox virus is isolated from both air and surface samples there as well. So we can see that there is a risk to those healthcare workers and anyone else that would actually be around at that time. And that's published in Lancet Microbe. This is an office investigation. This actually was in a hospital, but it was an administrative staff, and they didn't have any contact with any mpox positive patients. They came into work one day with non-specific febrile illness, sat at their desk number 12, and then the next day after they'd gone home, they actually presented with mpox virus became mpox virus positive, sorry. So a couple of days later, sampling was undertaken at all of these sites shown around here. And the green triangles indicate the occupied desks whilst that patient was actually in the office. But the only 3 positives by PCR were actually on the desk of the patient. And taking those forward, they were actually all negative when we tried to isolate any virus from them. And you can see they're quite high CT values. So actually, we wouldn't really be expecting to find anything there at all. During the height of the PHIC outbreak, we coordinated with some sexual health clinics in London to actually undergo surface sampling within those. And we chose 8 different sites within those sexual health clinic rooms. So we had a couple or 3 around the healthcare worker. We had a patient chair, and on the floor next to the patient chair, we had the examination bed, and then on the floor next to the examination bed. And those sites were swabbed once a week for 4 weeks. So we had 32 samples across the 4 weeks. And what you can see is we only detected 3 positive samples by PCR, again at quite high levels. But we took those forward for viral isolation. And actually, from sample 2F, so something very close to our limit of detection at 36 CT value almost, we actually managed to isolate a virus, viable virus. And this really sort of hits down that actually you can't really use CT value to try and identify whether a sample is got infection competent virus in it. So actually there is a risk throughout this, and this is being published in the Journal of Hospital Infection as well, so you can read about that. So in terms of environmental sampling to date, we found significant contamination, both surface and air samples in patient rooms and also domestic settings, as we showed in the 2019 incident. We saw lower outbreaks in outpatients, so in the sexual health clinics, but also the workplace settings. But they actually was still a potential for viral transmission because we were actually able to isolate the virus in some of those samples. So really, the presence of DNA isn't singly related to the actual sort of presence of viable virus. So something really to keep in mind going forward. And some of the transmission or the contamination likely factors, obviously the time spent in a contaminated environment and the level of contamination there. Obviously, more contamination means there's more risk to the person, and especially the longer time you spent in there. Also, the time since contamination. Some of the samples we took were sort of numerous days after that person had been in there, and it's something we want to study going forwards, is actually how does mpox virus persist in the environment. And we can sort of have a look at that through things like controlled climate chambers, where we can inoculate surfaces and put them in there and study infectivity over periods of time. And also frequency of cleaning. Obviously, you can still clean, but do we remove all the DNA, or do we just inactivate that virus as they're going forward? And also we can then we've been tying into infection prevention control measures and PPE guidance, which is being used. And that's actually really sufficient of what was actually already designed. And these HEID wards have been going for a number of years, and they've had lots of practice and lots of input from people cleverer than me, which is why they actually were very well prepared going forwards. And some of the data has been included in what we have as UK HSA technical bulletins on the gov.uk website. And this really sort of puts into what the current practices are. And it's designed to help health practitioners and academic and also public health agencies as well, with sort of ideas and sort of an overview across different briefings. Just got a final slide, and Sean presented this poster on it as well, so I don't know, hopefully everyone saw it. But what we wanted to look at, and we found some on, as I mentioned, about healthcare workers having positive clothing. So a lot of the healthcare workers, or in some areas, will actually use reusable clogs, and these are autoclavable. So actually it cuts down on the amount of disposable PPE, and they're a lot more comfortable to wear as well. And what we did was basically we inoculated the clogs with mpox virus DNA at the concentrations we found. And then we put them through a number of autoclave cycles and then swabbed them to actually try and see if we could still recover mpox DNA. And we could, basically. It reduced down, but we were still detectable by a PCR. So it's sort of a word of warning that even though you're detecting it in the environment, and again, it might not be viable, but obviously we've shown with low CT values as well, it could be viable. So it's a bit of a balancing act there to sort of go forward. And last slide, obviously there's a number of responses there, and there was a lot of people working on it. So it's very much a sort of a team effort from everyone involved there. And I think that's it. Cool.
Questions for Tom? Any on the chat?
Everyone wants to get a coffee. Oh.
Anne, okay, I'm coming. I'm coming.
You did a great job without your slides. You mentioned how there was a case in the UK and one in Singapore where it was generated from the bed linens.
Oh, yeah.
I was wondering what the cleaning procedure for those has been recommended.
I am not entirely sure about actually that. I think it goes through high temperature, obviously with detergent in the hospital environment. And whether that might include an autoclave step prior to that, I think, yeah, I'd have to look that up for you. Sorry.
Okay, thank you.
But you all have a test lab, right? That's like a
Yeah, so
hospital
that's something
ward.
we've got a mock hospital ward facility which we've just had built on site at Porton Down, and so we can study infection and transmission in the built environment. But one of the things we've got is some washing machines, so we can have a look and see about different washing temperatures or detergents as well, to actually look at reducing different infectious agents. And that's also to tie into domestic settings. During the PHEIC, people were quarantining at home rather than coming into hospital. So actually, is there an issue if your washing machine at home only goes to 40 degrees and you're putting your detergent in or whatever? So we can have a look at different parameters there and see how well they affect not just obviously mpox virus or different surrogate viruses, but also bacteria as well. So we can have a look at seeing about that.
Steve. Thanks. Steve Sandrowski, US EPA. So I was wondering, just going back to the one slide you had of the different sites that you swabbed in the mock room. How were those sites selected? I don't recall if you had mentioned that.
Oh no, yeah. So we just sort of looked at considerations of where people have been, but also it was a real mixture of sort of targeted sampling. So we didn't use really a statistical approach or anything. I know we could have done. We sort of used experience and sort of so really experience and of knowing where contamination might occur, but also we wanted to look around and seeing places which might not have been cleaned effectively and might pose a risk long term if viral material had gathered there. So we could look at windows or in things like the air vent between the actual treatment room and the bathroom, because all the air would go through there when the doors were shut. So actually we could use that maybe as a sentinel rather than air sampling. So we can have a look, and we used more of a targeted approach rather than statistical approach for the sampling there.
Okay. And how did you deal with the more complex surfaces? So like, for example, you had the keyboard, and if you put a template on there, it's
no. So yeah, so it was sort of semi-quantitative in a. So if we had a flat surface, we could use our template. So as mentioned, we have like a 10 by 10 plastic template we can put on the surface, and we can go over with our swabs. But if we have something a bit more, a bit smaller, or we don't know the topography, or we can't quantify the size of it, the surface area, then we can sort of use that and just say, well, we found this per remote control or per keyboard. So we can sort of do that. So it's a bit more semi-quantitative rather than a fully quantitative sample.
It seemed like some of your results or your anecdotes of detecting mpox during bed linen changes or other activities. I'm thinking about buses and people sitting on seats may warrant some kind of activity-based assessment of.
Yeah, I think
risk.
So in terms of the bed linen change, I think it's slightly different than someone sitting on a bus, because people are fully clothed. So if they have scabs or if they have pustules, then it will stay on their clothes. It might transmit through their clothes a little bit, but actually in a bed change, you've got that physical contact between yourself and the sheet. And that's what we thought with the sexual health clinic, was actually we're getting the contamination on the floor because people are changing out of their clothes there to then be sort of inspected by their healthcare worker. So actually they're putting clothes on the floor, or they're rubbing themselves, getting their clothes off, and it's falling onto the floor. Whereas sitting on a bus seat or on a plane, I think is slightly different, because you're not directly contacting those areas. But I think it is something to look at, and I think it is a big area that's sort of a bit of a can of worms sometimes when you
at least for
how
like
much do you look?
banding risks for understanding where exposure risk lies. Yeah, you mentioned scabs. I'm surprised you didn't bring up your scab collection.
It's not mine, it's Barry's pride and joy. So it's
Lindsay.
Thank you. Sorry if I didn't quite catch it. Some of the tables, the text was small, but
yes.
for the samples in which you were able to isolate infectious virus. What was the sampling method used to process those samples? And were you able to identify any infectious virus in the Copan UTM?
Yeah.
Um,
So basically there was a, in terms of if I said surface sample, it would have been flock swab with UTM. So that would have been initially aliquoted off for PCR. And then we kept the rest of the sample, and we could then process it if we did find a positive, if we wanted to. With the air samples, we used the gelatin membrane or gelatin filters, and we could dissolve those into cell culture media, and then again PCR, and then keep the rest of the sample for processing by viral isolation. And that would have been that's in, I think it's Vero E6 cells, I think. So it's going forwards with that, and we look for cytopathic effect. And then we can also do PCR on the supernatant as well to see if there's any replication rather than just sort of cytopathic effect from anything in the sample.
All right. Thanks again, Tom, for overcoming the AV challenge.